Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our conversation with Cancer Expert series, we have a leading figure from the Asian subcontinent on multiple myeloma. He's also professor and head of department at the Armed Forces Medical College in Pune, India. We're privileged to have him on our podcast today. Welcome, Dr. Uday.
Thank you, Dr. Vich. Thanks for inviting me for this important podcast series.
So we'll go ahead and get ready with our discussion. So in terms of the, you know, uh, multiple myeloma, what are your views on the epidemiology of multiple myeloma in India? How is it different than the rest of the world?
So when we talk about the epidemiology of myeloma, we have few numbers to quote. So the incidence of myeloma is 1.27 for 100,000 in males and 0.95 for 100,000 in females from the India. So this is from a cancer epidemiological data by the National Cancer Registry. And the prevalence, which we have collected by the Indian Myeloma Academic Group from 62 centers across the country, the peak centers, we have approximately 1.5 lakh or 150,000 patients who are actively having myeloma currently being treated at these centers. Now, if we look at the incidence and prevalences, the incidence is different in different parts of our country. So in the southern and the northern zones, the incidence is slightly higher. When compared to the Northeast India, this is based on the ethnicity and the genetic profile, which are different in different parts of the country. Also, what we have seen is that when we collected this information from the National Myeloma Registry as part of it, we have these different numbers from different institutes. So though most of the patients prefer to go to the top institutes, but this still gives us a broad idea about the regional differences in the country and how the myeloma is different in different parts of the country. To understand this better, and the way we have the iStop MM and the Olmsted County study from Minnesota, or the PROMISE study by Irene Gabriel from the US, we tried to get some similar numbers for the monoclonal gammopathies from our country. So this is a last 3 years effort which we are putting together by the armed forces along with the Indian Myeloma Academic Group. So we have done this study in 3 phases. First phase, we collected some data from the rural areas of the Maharashtra. Then we went to some tribal or aboriginal populations in the phase 2 in 2024. And in 2025, we went to the northern and the eastern India. By spending approximately close to around 2 million man hours and collecting door-to-door data from approximately 118,000 patients, we got these numbers at the end of doing a door-to-door survey. And based on these numbers, the prevalence of monoclonal gammopathies in the country, now we have some clear numbers. So above the age of 45 years, it's around 1.04%. Above the age of 55 years, it was 1.8%. And above the age of 65 years, it's 2.43%. So this is the prevalence of monoclonal gammopathies in India. This was recently presented as an oral paper in the International Myeloma Society. So to summarize the incidences and the epidemiology, we would say that the prevalence of monoclonal gammopathies is much less than the West, where the quoted numbers above 65 years is 3 to 5%. The incidence, though, is at par, probably because of the change in the overall survival and the 4 different parts of the country, the North, East, South, and West. We have regional differences because ethnically and genetically, they are different cohorts of people.
That's remarkable what you've done with limited resources. Congratulations on putting together this detailed presentation, and congratulations on your presentation at the International Myeloma Society. So what are the peculiarities of myeloma in India that you found?
So, sir, coming to the peculiarities, firstly, we have a prevalence more in the younger population. Now, this is the data of around 80,000 myeloma patients that we have compiled in our National Myeloma Registry from the country. And we have realized that the median age is almost a decade earlier. Now, we would We are trying to verify this by a source document verification and checking out, are we missing on the older patients who are not reporting to the hospital, because this is hospital based data. So, but still, all said and done, when we compare these figures with the Latin America and with the lower middle income countries of sub-Saharan Africa, we have a population which is adolescent and young adult myeloma, which is more common in our country when compared to rest of the reported literature in the world. Now, the second thing is, many of the patients come very late as far as the presentation to the physicians is concerned. And because of this late presentation, the target organ damage figures are much higher when compared to anywhere in the West. So the bone disease is seen in 85.4% of the patients at the diagnosis, with anemia being present in 76.2%, renal dysfunction present in 54% of the population, and hypercalcemia present close to 50% of the population. Now, these numbers are alarmingly very, very high. And we then cross-check this information with few institutional data. So this is the North Indian data that we have looked at, wherein this map shows all those red dots are the ones which is the distribution of the patients who are being treated from Delhi, and the black dot shows who have expired. We have compiled this information together, and if you see on the right side, the hypercalcemia is close to 60%, the renal failure 60%, anemia 74%, and bone disease 88%, which is almost similar to the national registry data. So this is a published literature which was published in 2022 of the North Indian data of the disease characteristics of the patient, and we try to analyze the outcomes based on this. And also, if you look at the ISS, most of the patients present in ISS 3, that is almost around 61% of the patient. This again shows that this is a late presentation in the country, which is a major factor which leads to a low outcome. This other problems that we have is the resource constraints, because we being a low and middle income country, poor follow-up of the patients. Despite of patients trying to come to the tertiary care hospitals, the follow-up is extremely poor. The transplant conversion ratio is less than 20%. Now, this is a major factor. We have 80,000 patients, and when we looked at the number of patients who are transplanted annually for myeloma, they are close to around 600 to 1,000 patients. So the transplant, which still remains to be the backbone of myeloma therapy, everybody is not getting converted to transplant. We will discuss about it in a few slides more about why is the problem with the transplant conversion. But this is one place where we feel that we can do a lot in the future. Now, this is the data from various hospitals and the median follow-ups and the overall survival of the patients. And we see that because of the lack of transplant, the overall survival at 5 to 3 years is much less when compared to the West. Now, drug compliance is another major problem in the country. So we did a study from PGH Chandigarh, a 15-year prospective study to, I would say, ambispective. We first started it as a retrospective study, then converted it into a prospective study. And we looked at what is the major reason for the patients for not having compliance or a change of therapy. So though we thought finances are the major cause, but actually it is a toxicity to the drugs and the persistence of the disease. And this was primarily because of the four major factors. One, high reliability of complementary medicines or alternative medicines in the country. So despite of good awareness, education, counseling sessions, many of the patients after 6 months to 8 months, they switch over to other complementary or adjunctive medicines. Second, the generics. Now, India, though, is the hub of generics in the world, and that's a boon, but also it's a bane because the quality control of the generics is not ideal. We have drugs, generics being produced from different parts of the country, from different types of laboratories, and we have found that the QC of generics is second major problem for compliance issues. The cost of the research molecules. If we want a homogeneity in the care, and if we want everybody to take research molecules, then cost makes a major problem. Non-affordability to second-line drugs. We all understand myeloma is a chronic disease. It's no more a disease wherein we have a limited therapy. So every patient would relapse at certain form of certain timeline of the disease. At that point, giving a monoclonal or a bispecific or a CAR-T or the newer forms of therapy becomes non-affording for most of the population, 94% of our population. That's a problem. So lack of treatment guidelines, which amalgamate all these factors, and put across what is ideal for our country is another major problem. And because of this, there are inter-institutional treatment practices which are different. So Tata Memorial would treat differently, AIMS would treat differently, PGI would treat differently. So we have found that there are major differences in the way these within a country, the various centers, they manage their respective patients. So to get over this problem, we came about with one consensus guidelines in 2016, and we are now coming up, because it's been 10 years since the last guidelines, we are now coming up with a second set of guidelines, of consensus guidelines for the Indian specific scenario. So to summarize, the Indian patients are younger, their challenges are slightly different, and most of the patients present late in the disease with target organ damage. So these are the key factors which are peculiar to our subcontinent when compared to the rest of the world.
That's again remarkable that you have such granular data on the Indian population. Keep up that fine work. So, what are the specific challenges in diagnosing myeloma in India?
So coming to the challenges, I would classify them into two groups. One, the resource constraints, and second, the problem with diagnostic facilities. Now, when we say diagnostic facilities, now India is a country where I would go to the next slide just to share that though we have had Mars missions and Gaganyaan missions to go and reach the moon, but the problem is still the travel in a local conduit by even auto rickshaws is difficult. So we are a heterogeneous group of population wherein we have a certain set of population who can afford everything and anything, and we have certain set of population who can't even afford the basic tests. So this heterogeneity is one major problem. Now, there are certain basic tests which we all want for diagnosing myelomas. So there is a lack of universal availability of basic tests across the country. So most of the rural population still have to come to tier 2 or tier 1 cities to get the basic tests done. And they lose a lot of money, though these basic tests are very cheap, but the conduit itself or coming and going back for getting this test done is very costly. So when we do a Markov model, actually the test monitoring or getting diagnosis becomes difficult because of that. Now, even the advanced tests, the world is moving towards NGS at baseline, trying to re-stratify them with the newer genetic variants. The problem is these advanced diagnostic tools are limited only to the top academic institutes or to the premier lot in the country, and they are not accessible or available to most of the population of the myeloma. Now, we did another study, which I'll show you in the next slide, about what is the availability of these tests across our country. And lastly, most of the patients, before they come to even to the tertiary care center, they get evaluated at a peripheral place where they don't get evaluated thoroughly. They are started on some regimen, and by the time they come to us, they have already 2 or 3 cycles down the therapy. Now, I can't do a genetic evaluation again. I can't do basic tests again. I don't know what risk stratification the patient is belonging to tailor my therapy. So this referral system, unlike in the West, so the patients get diagnosed and treated upfront by the peripheral physicians, and then they are referred after 2 to 3 cycles to a hematologist or an oncologist. That's another problem as far as diagnosis in the country is concerned. Now, for the investigations, most of the country, they rely on outsourced investigations rather than institutional investigations. And when we talk of outsourcing, there's a lack of standardization, there's an interlab variability, and the QC for most of the tests are not very clearly defined. Though we have a NABL and a NACC accreditation, but for the basic tests, the standardization and interlab variability is huge. So those are the challenges that we have. To overcome this, what we did is, though these are all the tests that the people advise as a state-of-the-art workup in most of the international guidelines, we said that we can actually do away with few of the tests. And this is based on a treatment accessibility and availability study, which was published this month in our CLML, clinical lymphoma, myeloma, and leukemia, wherein we tried to analyze what is available, what is not available in different parts of the country. And based on that, we came up with an algorithm. We said these are the 3 essential steps. When we talk of testing myeloma, these are the 3 core elements. And to match these 3 core elements, can we do, rather than a blunderbuss evaluation of all the tests upfront, can we sequence the tests so that we can cut down the cost? And we came up with this algorithm along with Dr. Shaji Kumar and Dr. Vincent. And this is up for publication in the press. And we are coming out with these guidelines of how to go about with sequential evaluation rather than subjecting all patients to all investigations upfront. And this would cut down the cost. And this is more or less similar to the NCCN guidelines for the sub-Saharan Africa, where they have advised few tests which be omitted. So similarly, for the Indian part, we are coming up with these guidelines of diagnosing in the upfront settings. And these are the guidelines which are submitted to the press and which should be published anytime in the next 1 month. And this was also discussed as a LMIC discussion during the IMS, wherein I was a member of managing myeloma with limited resources. And also in the Asian Myeloma Network, we are coming up with a resource stratified diagnosis and treatment. So by doing these things, we might be able to make sure that these lacunas or challenges in the diagnosis can be overcome partly. So this is the summary of what we have discussed. So there's a diagnostic heterogeneity, there's a heavy reliance on outsourcing, and there's a limited access to most of the advanced testing techniques requiring country-specific or region-specific guidelines for how to diagnose myeloma.
Once again, kudos for going and doing such a thorough dive and trying to come up with these specific algorithms. I think this will not only be relevant to India, but it will be relevant to other parts of the developing world, certainly. So, what are your views on the availability and access overall for myeloma care in India?
Sir, this is a wonderful part that you have touched upon. So when we talk of access and availability, there's a subtle difference between availability and access. The drug might be available, but it might not be accessible to most of the people. So we require to differentiate the terms availability and accessibility. Now, if we summarize all the treatment options that we talk of myeloma in the current world, so this is a summary of all the drugs that we generally use. Now, out of these drugs, all those which are marked in black are available in our country. Now, those which are marked in orange, that is ixazomib, elotuzumab, isatuximab, selinexor, erlantamab, and talquetamab. These are the drugs which we are going to have the availability in the next 6 months to 8 months in the country. So that makes it that we have 98% availability of all available products in the world within India. Only drugs which we are not seeing to come up in our country in the next 1 year or 1.5 years are the CELMoDs and the antibody drug conjugates. So apart from that, we have most of the drugs available or going to be available. But when we look at the availability versus accessibility, you'd find that India has availability of most of the drugs. And if we look at the generics, you'd see that most of the drugs except the monoclonals and the bispecifics are even available as generics in the country. But when we look at the accessibility part of it, we would realize that out-of-pocket expenditure is almost 70% in the country because of lack of good insurance policies, or even if they are available, the insurance policies, patients are not aware of it. And we did in this article a thorough drug-to-drug evaluation of availability versus accessibility. But to keep it simple, the issue is the drugs are available, but they are not accessible to almost 70 to 75% of the population. Now, the next aspect is any country grows when we have good schemes to develop. So there are a lot of national schemes or the central schemes which are provided by the government of India, but most of them are not aware. Most of the patients are not aware of these schemes. So in our particular Indian Myeloma Academy group on the website, we do this. We have this page wherein all the schemes which are centrally as well as state-wise which are available are put there so that the patient can go through that particular part and they know how to apply for these schemes. So we have summarized all these schemes on our website. But despite of doing that, what we have realized is when we talk to the patients, many of the patients, because of the educational status and because of lack of understanding of the social media things, many patients are not aware of the government schemes which are there, like Ayushman Bharat and etc., to help them in getting their treatment. So to further that, what we have done is we forward a patient support program to through the Indian Myeloma Academy group, which we have founded in 2017. So we provide transplant bricks to almost 10 patients in a year. And these are the various patients who get transplant bricks. Whoever require a transplant and not affording, we provide them free of cost. We also provide them investigations free of cost on an annual basis. Whoever apply to us, we are coordinating with various other agencies like Care India and other NGOs to partner and to help them in forwarding this information of what are the sources from which they can get the drugs free of cost. So to summarize the availability and accessibility, the first important factor is there's a major out-of-pocket expenditure because of a lack of common insurance infrastructure or a government infrastructure across the country. There is a limited access to advanced treatments. And though we have an improving government support and a treatment revolution through generics, but it is not reaching the grassroots level or the last mile delivery is still what we need to work upon.
Again, kudos. So, in terms of access, obviously now CAR Ts are available in India. You mentioned teclistamab is available. So, how many institutions are set up to deliver, say, CAR Ts in India? Do you have any idea of that at this point?
Yes, sir. So CAR-T, currently we have an academic CAR-T. So the commercial CAR-Ts are out of reach even for the premier lot in the country. So though we have total, we have given 42 CAR-Ts in our country till date, of which almost around 28 are the ones where the CAR-T was imported from the China or Singapore, and wherein the patients were given the CAR-T. None from the Cilta-cel or Ida-cel, none of the patients have got that. But coming to the academic CAR-T, which is a homegrown, so we have a phase 3 trial which has just got concluded, in which we have given 24 patients that. And by the turn of this year, we would be ready to give academic CAR-T, which is homegrown in 8 institutes in the country at very affordable costing. Just to $10,000 to $12,000, we would be able to provide a CAR-T for the patients. Now, coming to the teclistamab or bispecific, till yesterday night, we have 152 patients who have been given the teclistamab in the country across approximately 84 centers. Most of the centers have given 1 or 2 patients, but 84 centers are equipped currently to deliver bispecifics in the country.
Oh, it's remarkable that you have data just as of just 24 hours ago. That is something that I must say is remarkable. So, what is the status of research and clinical trials in the field of myeloma in India?
So this is one place where we need to actually evolve and we need to develop. Now, we did a study, and this was again presented in International Myeloma Society last month, wherein we compared the various trials across Asia and we tried to look where are we when compared to the other Asian countries. When we look at the observational studies, the highest number of observational studies are from China, followed by India. But when it comes to interventional trials, we lag way behind the other Asian counterparts. In fact, small to small countries in the Asia have got more number of trials when compared to India. China has almost around 140 to 150 CAR-T trials going on, whereas we have one CAR-T trial going on. And most of the pharma trials, we are lagging. Now, lately with the government policy of having for any drug approval, they have said that it needs to undergo a phase 3 trial in the country. So in the last 1 year, we have around 11 trials which have come to the country, which includes bispecifics, trispecifics, ADCs, and also some CAR-Ts which are not homegrown, some Europe-based CAR-Ts. But this is one place where we are lagging and we need to develop. Again, on our website, we have the various setups wherein we have all the active trials we put up there, and we put up the center with the target patients and what are the inclusion and the exclusion criteria. So like this is one of the trial for the monumental trial wherein the people are currently being recruited for teclistamab with calcitamab. So like that, the active trials, we project it on our society website. And also there are trials which the Indian Myeloma Academic Group is doing. So why I had this information when you said that we have the information as late as yesterday. So we have a study known as SEHAT, which is safety, efficacy, and health after teclistamab, wherein we are trying to collate the data of all the patients who have got bispecifics. Similarly, we have a trial on the immunotherapy, wherein the patients have been given CAR-T, and what is the real-time effect or the real-world information about what's happening to the patients, the quality of life studies. So we are doing it as a group, Some we are doing it as part of institutes as investigator initiated trials, but all said and done, the number of registered trials as of now from our country are only 32 trials, which is way lower than any other country in the world. So this is one place where we need to evolve to. So this is the place where we need to work upon and actively advocate people to initiate more trials and participate in more number of trials.
So, as far as the availability of CAR Ts go, you are talking about the academic CAR T. Do you have any data that you're able to share at this stage about outcomes from these indigenous products? Are they at par with the ones that have been reported in the literature?
Sir, we have the data from the phase 1 and phase 2, which is out in already in the public domain. So they were presented as ASH posters. And in fact, they have shown that the survival or the PFS is much better when, or at par. I would not say much better because there's no head-to-head trial, but they are comparable when compared to the other CAR Ts in the West. So that was presented last year in the American Society of Hematology by the group from St. John's. Dr. Hari Menon had presented that paper there. So that shows really promising results, but the phase 3 results are yet to be analyzed and put up in the public domain.
So, and as regards bispecifics, are there, to your knowledge, any indigenous efforts to, because India obviously produces, biosimilars for monoclonal antibodies. Are there any moves afoot in the near future to have some indigenous capacity to produce these bispecifics, to your knowledge?
So for the monoclonals also, till now, daratumumab is still a patented drug in our country. That's still the patent is till next year, December. But there are two companies which have come forward, the Indian companies, where they are producing daratumumab currently, the biosimilar for the monoclonal for daratumumab, where the trials are starting this December. And we would probably have by the end of next year, by the time the patent expires for dara, we'll have generic or the biosimilar dara. For the bispecifics, because of the patent loss, still no company has yet ventured into a bispecific, a homegrown bispecific, though there are two companies which are working on starting for T cell receptor targeting, but that's at phase 1 level stage still. So it's at very nice stage, and they are just still in a proof of concept mode yet.
Well, I'm sure they will, be there in the few years, given the remarkable progress that has occurred overall in CAR T. I can only imagine that the bispecifics are not going to be too far behind. So, based on the challenges that we've discussed, what are the steps taken in the direction of improving awareness and advocacy?
Sir, again, I would say this is a beautiful question to be posed because all said and done, whatever we are progressing scientifically, till the time we are not able to deliver it to the patient, these are all useless. So the awareness and advocacy are extremely important. And I'm happy that you have touched on this point. So first thing, as government of India has actually taken a campaign of saving the lives of many of the cancer bitten patients by reducing the GST to 0% for all life-saving drugs. And luckily, all the myeloma drugs are now having free tax or 0% GST. So this has brought down the cost of the drugs tremendously within the country. So this is the first important step from the country, and this is thanks to the advocacy by various patient groups, by the Indian Myeloma Academic Group at the ministerial level, and we could try to include the myeloma drugs as part of this campaign of life-saving cancer drugs. Now, we have many patient groups which are active, and we are very happy to be associated with most of them, like Myeloma Friends, Yodhas, Myeloma Warriors. So there are many groups, and these groups, they meet regularly. We almost have a weekly to twice weekly patient support group webinars, which are area specific, region specific, and they are conducted in local languages because India has got 26 different dialects. So most of these groups, they try to target local population, and they try to convey all this information for empowering the patients with the information about the latest in the field of myeloma and improving the morale of not only them, but also the caregivers. We also have Hematology Cancer Consortium, which works extensively on yoga, inner healing, and integrating yoga into the myeloma care for improving the mindset and for empowering the patients and their caregivers. So these are the various activities that keep taking place by the different groups. Now, from the Indian Myeloma Academic Group, we have a mobile app wherein all this information, all the latest information, the various NGOs which work on it, the government schemes, the various doctors who deal with it, and the available drugs. We put everything on this app, and this is directly available to the patient, and this is free of cost for all the patients. Also, as the Indian Myeloma Academic Group, for the patient education, we have what is known as a myeloma map. So this is a patient guide. This is available in 14 different languages, and the patients can understand the basics of myeloma, how to diagnose the early symptoms, how to navigate through getting the evaluation done, and what are the treatment options and living with the myeloma. So it's all available in this. Also, what we have done in our country is we have tapped the young talent, that is the medical graduates or the undergraduates who are doing MBBS. We tried to bring in a FAME lab concept, which is there in the West, wherein we have something on STEM talks, wherein they can integrate science, technology, engineering, and medicine together to convey the message to the patients in the local dialect. So we every year we put this challenge to all the MBBS colleges in the country, and we ask them to create videos about how to convey the education material to the patients in their local dialect. And we have different languages, different students doing different activities, and we put all these things on our website and on the mobile app and on our YouTube channel. These are available to the patients, and they are heavily subscribed because the MBBS students try to bring them out in a layman terminology. And with this, we are trying to educate the patients more and more. And last year, we started a concept known as a Resonate. So as the National Medical Council, they have brought in a concept of ATCOM, wherein they want the communication skills of the MBBS graduates to improve. So we integrated the communication module of the National Medical Council with that of the myeloma, and we have asked them to communicate different topics of the plasma cell disorders, and we sponsor the students for whatever cost that they have in doing that, and we have made it as a activity or a competitive event, and most of the students come forward and do that. So to summarize, the patient support groups, the educational efforts by the Indian Myeloma Academic Group, and by the young graduates, putting it together, we are trying to improve the awareness within the country, but we have a huge journey to undertake. We are still taking baby steps, and we have a long way to cover before we say that our patients are well educated and are aware about their disease well.
But that's not for lack of trying. The kind of innovative solutions you are looking at and all the tech-based solutions, these apps, that's kind of amazing. Is this something that other disease states are emulating, or is this effort far advanced in myeloma than some of the other heme disorders?
So we started this way back in 2017. So it has matured over last almost around 8 to 9 years. The other hematological disorders have started emulating it. Now we have certain applications for hemophilia, for sickle cell disease, for thalassemias, which have been started for last 2 to 3 years. And in fact, the government has taken up few of these projects from us, wherein we have shared the IPR free of cost to the government of India, and they are trying to emulate that as far as the blood cell disorders is concerned currently. So we need to learn from each other, and definitely the best practices should be emulated across hematological practices and other disorders as well, so that the diseases can be actually treated well by the last grassroots level physician, or what we call as a primary health physician well. So that's the aim that we are targeting at.
So, what are the future directions of myeloma care in India?
So coming to the future directions, we are targeting four important aspects. One, to expand the access to the transplant and to the novel agents. So one, we are trying to do advocacy. We are trying to collaborate with the industry. We are partnering with them for the various generic drugs. Whatever the new drugs are coming in, we are giving them a free hand to do trials for them as soon as possible so that they get into the market fast. So One is expanding the access, though we have availability, but to expand the access. Second, to integrate myeloma into the national cancer control programs. Now, for breast cancer, there's a program. For this lung cancer, there is a program. And for the oral and head and neck cancer, there's a program. But there's no program yet for any of the hematological malignancies. So we are almost at an advanced stage with the government of India. And probably in the next 1 year, we'll have a specific special myeloma control program, which the government is going to launch. So we are hopeful once that comes into picture, most of the therapy or the access would automatically improve, because then all government institutes will be mandated to provide free myeloma care. Now, improving the research infrastructure is another target that we as a group are trying to do. And lastly, promoting early diagnosis through awareness. So every year we do these annual conferences in different parts of the country. We do quarterly conferences in the tier 3 and tier 4 cities, wherein the target audience are physicians, the MD physicians and the primary healthcare physicians, for them to understand the early symptoms of myeloma so that they can promptly refer these patients or evaluate them upfront without waiting for the target organ damage to take place. So these are the four things, and the Indian Myeloma Group, academic group, is actively working on it, and we have various support programs wherein we sponsor most of the students to go to the West and get the fellowships, get knowledge enhancement in various laboratory as well as in the non-laboratory fields. And this is at undergraduate, postgraduate, and DM level. So we have been actively trying to do that. And this is the next conference that we are having in the month of January this year coming up, wherein we are trying to act upon all these points that we have spoken about to develop on it more and more with various international partners and the international faculty like you who are coming and trying to educate the Indian doctors. So we thank our international fraternity who are taking every step to help us out in each of these activities.
I think you are doing, such great work that what the international faculty is doing is probably minuscule, but it's just amazing. So, what would you like your concluding comments to the audience to be?
So to conclude, I would say collaboration is the key. So whoever is working in whichever field, we should not work in silos. We should work hand in hand. And we are trying to collaborate internationally, nationally, between institutes and institutes to rural level. So we require collaboration or bridging at every level. So that's first most important thing. And along with that, we need to understand that India presents a unique landscape as far as myeloma care is concerned. And we need to understand the regional problems with the regional gaps by a gap analysis for the diagnostic and treatment approaches. And we need to bridge those gaps. And lastly, this all can only be done by handholding, and we request people like you to come forward and handhold us and take us forward and show us the right path.
I think you should be the one who should be holding our hands. With depending on what you've done is just amazing in a resource constrained environment to have the foresight to look through things and to come to this point. Obviously, a lot is a group effort, but under your leadership, I think myeloma is a trailblazer, which others in India and in other parts of the developing world and even the developed world, where there are resource constraints, need to emulate. So I think you are someone that is giving far much credit to international collaborators, and what you've done is just remarkable. So I think with that, I will say keep up the great work. Obviously, there's a lot more I know will come from the group that you lead here. And I look forward to being able to talk to you in the future as you make additional joint strides and actually leaps. So keep up the good work, and thank you for all you're doing. And thank you for doing this podcast here today.
Thanks a lot, sir. I would like to thank you more importantly for giving this opportunity to discuss out a very relevant issue and to hear out the challenges in this part of the world. And definitely, so you people have been the leaders in this field for decades together. We are all juniors who are learning from your experiences and your expertise in this particular field. So we look forward to collaborating more and more with you, sir. And I really thank you for these kind words. But yes, as you rightly brought out, this is not individualistic performance. It's a teamwork. So like-minded people across the country have come forward to put this all together and take this forward. So thank you once again, sir. And I would like to say Jai Hind.
You put us all to shame. Jai Hind.